Well, welcome everybody. We are members of the Association of Physician Assistants in Cardiology, and we'd like to welcome you all to our webinar tonight, focusing on EKG interpretation. Thank you for joining us during the busy last week of summer. We're honored that you're here, spending time sharpening your skills, and whether you work in primary care or cardiology, you're a nurse, a doctor, a physician assistant, or nurse practitioner, all are welcome. And we are in for a treat. We have Dr. Schiavone here, a well-known and respected physician, and I'm happy to introduce him. Dr. William Schiavone is a 1978 graduate of the Philadelphia College of Osteopathic Medicine. He finished training in internal medicine and cardiology at the Cleveland Clinic, where he started and finished his career in cardiology. In between, he practiced in Akron, Ohio, and was professor of medicine at Northeast Ohio University's College of Medicine and made daily rounds with the residents. You will find that it is clear he enjoys teaching. He then moved to Geisinger Medical Center, where he directed the section of non-invasive cardiology and taught cardiology fellows, where he developed this method of teaching, electrocardiography. In retirement, he brought his method of teaching EKG to all who want to learn. I am privileged to have used his program for EKGAction to fine-tune my own EKG interpretation skills. And even almost after 20 years of practice, I still have found I have some things to learn. Dr. Schiavone, we are excited about your presentation, and thank you for joining us tonight.
Thank you, Laura, and thank you, Viet. Viet, did you have any forewords, or should I just share my screen?
No, Laura did a fantastic job, and I just I'm excited to see your presentation and look forward to a wonderful evening here with you.
Well, thank you. So let me get started on this PowerPoint slide. All right, is the screen easy to see?
Yes, it looks great. It looks great.
Okay. Well, let's get started. So here's the title, EKG Interpretation Tips and Tricks. And let's see if we can move forward with this. It seems like it doesn't want to move. Son of a gun. So I will stop sharing and maybe share again. And maybe try this PowerPoint slide. Share this one. There you go. Here are my objectives. At the end of this webinar, participants will be able to identify the relationship between the EKG and the cardiac action potential. We'll look into that. And be able to use an orderly guide of EKG interpretation in 17 steps that I recently constructed. And recognize that similar EKG tracings can be due to different etiologies that must be differentiated. And once again, it pauses. Let's see. Let's move again. There we go. So the EKG and the action potential were discovered at different times. The EKG is the real-time sum of the action potentials of all the cardiac cells. The first EKG was recorded by Willem Einthoven in Holland in 1895, and he based it on the string galvanometer that Galvani invented about 100 years earlier. But it was in 1924 that Einthoven received the Nobel Prize in medicine for his EKG. The action potential was attributed to Andrew Huxley in England in 1952. And he was awarded the Nobel Prize in Physiology or medicine in 1963, along with his co-workers, Eccles and Hodgkin. Look at how many years after the EKG, the action potential was really elucidated. Well, the next slide integrates the action potential and its cellular physiology with the practicality of the EKG. so we can understand electrophysiology in health and in disease. So here's the action potential on top. It's a cardiac cell, and it has 5 phases from 0 to 4, but 4 is the resting phase. So it has a negative 90 millivolt resting potential. So the charge is negative. It's polarized. Well, in order to get depolarized, it needs to lose that negative charge and lose that polarity. And it actually overshoots a bit during phase 0 up to plus 25 millivolts. But then when those sodium ions stop coming in through those channels in phase 1, it approximates 0. So it is depolarized at about that point there. And then that about terminates the depolarization that you see on the electrocardiogram, which with the QRS, because both the action potential and the electrocardiogram have the same time scale. Then during the phases 2 and 3, it's repolarization. When calcium ions enter and potassium ions exit in 2, and in phase 3, potassium ions exit. And so this is repolarization that makes the ST segments and T waves. Well, think about calcium channel blockers. And calcium channel blockers will have an effect upon this phase 2. And that's the way they change the effective refractory period and can act as an antiarrhythmic drug. And drugs like amiodarone work in this phase 3, and that's how they can prolong the effective refractory period. You know that during the action potential, you cannot depolarize that cardiac cell again. So if you prolong it, you will oppose arrhythmias. So I guess we need another slide, and somehow there it goes. So I'd like you to know the definition of all the 89 ABIM style answer choices, the patient's presenting complaint, any past medical history and previous tracings if possible, and of course the voltage standardization and paper speed. I'd like you to know these before you read an electrocardiogram. And while you're reading that electrocardiogram, consider multiple explanations for the findings. What else can mimic this? So here are those 89 ABIM style answer choices, and they're divided into general features like a normal EKG, incorrect electrode placement, artifact, or P wave abnormalities, enlargement. How about atrial rhythms, junctional rhythms, ventricular rhythms, AV conduction, abnormalities of voltage or axis, ventricular hypertrophy, conduction disturbances, myocardial infarction, ST, T, and U wave abnormalities, clinical disorders, and we'll cover the majority of these, and pacemaker function. So here is the basics of EKG interpretation in 17 steps that I came up with. And after the lecture, if anyone would like, I'll show you the expanded 17 steps that have all of the definitions of those 89 answer choices in them. And they're underlined, so you just can look for that diagnosis and find examples. So identify the patient by name, age, and clinical presentation. Identify the atrial rhythm, the ventricular rhythm, and how they're associated. What's the PR interval? And while you're measuring that, think about AV block, junctional rhythm, pre-excitation. What's the QRS voltage axis? Are there hemiblocks or ventricular hypertrophy? All things that go into determining whether hypertrophy is present. What's the duration of the QRS? Is there a bundle branch block or an intraventricular conduction disturbance? Like we saw during repolarization, during those phases 2 and 3 with antiarrhythmic drugs, are the ST segments, T waves, and U waves normal? Consider acute myocardial ischemia, injury, infarction, and can you locate it? Consider patterns of pericarditis, and there are 4 of them. We'll try to cover some of that. Consider ventricular hypertrophy, QT interval, and know how to calculate it, know what the normals are. Consider electrolyte disturbances. Consider patterns of central nervous system disorder, hypothermia, dextrocardia, and its mimic. Does the patient have a pacemaker? What chambers are being paced? And is it sensing and pacing normally? So here's our first case. It's a 68-year-old female with intermittent palpitations. Let's go over the method of recording this electrocardiogram because it's a little different perhaps from what you're used to. It's older, but it has very good fidelity. So if you look at this tracing, it is a 3-channel recorder. So it records leads 1, 2, and 3 simultaneously. Then there's a broad line that separates these 3 leads from the augmented limb leads. But then here's a vertical line that separates those augmented limb leads from the V1, V2, and V3. And then it goes back to a broad line separating V1, 2, and 3 from V4, 5, and 6. And then it terminates with a voltage standardization, which is the usual 10 millimeters is 1 millivolt. The paper speed is 25 millimeters per second. And so if 25 millimeters is a little bit less than an inch, you can fit 10 inches of recording on here. So an easy way to determine heart rate, and these lines don't interfere with the rhythm, everything comes on time. You've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 beats, and you multiply it by 6. So you get 60 seconds. So this is a heart rate of about 90. So intermittent palpitations, that's the reason that this EKG is done. Well, here's coarse atrial fibrillation, but there are narrow beats and there are wide complex beats. And so what's the reason for this? Well, there's intermittent left bundle branch block conduction. Can that cause palpitations? Well, I've been party to enough stress tests where people start out with narrow QRS complex, and as the rate increases, the patient develops a wide QRS complex. And that wide QRS complex is recognized by the patient instantly. There are the palpitations. And then in cool down, when the rate slows and the QRS narrows, those palpitations go away. So yes, this is a reason for the palpitations in some patients. Now, I promised that I'd show you cases that look similar. So if you stand back a little bit, you can say, well, there are narrow complex beats and wide complex beats. And there's atrial fibrillation. But these wide complex beats, although they also have a left bundle branch block pattern, have a pacemaker artifact in front of them. So these are pace beats. And I guess the only other thing that you can see here is that the time from the last sensed intrinsic beat and the first pace beat is a little bit longer than it is between pace beats. And that's called hysteresis, and it's a programmable function. And it's used to try to preserve pacemaker battery life. Keep that in mind in case the first pace beat is longer than you'd expect. Here's case 3, a 76-year-old female with worsening dyspnea. Well, there's no rhythm strip on the bottom of this, but it looks like there are wide complex beats with a left bundle branch block pattern, and there are multiples. Let's look at a rhythm strip and it'll help us. So this is lead V1, lead 2, and lead V5. And here's a single such aberrantly conducted beat, 3 more, and then 5 more. It's in the setting of a supraventricular rhythm, but it's not regular. It's irregular like atrial fibrillation, yet there's a quite an easy to determine P wave, and the P waves vary from beat to beat. It's tachycardic, so this is multifocal atrial tachycardia. Go back and look at what the rhythm, what the complaint is, worsening dyspnea. Well, people with lung disease are the usual patients to get multifocal atrial tachycardia. Notice how these wide complex beats always follow a long interval and then a short interval, a long interval, then a short interval. And this is called Ashman phenomenon. Ashman phenomenon has a right bundle branch block pattern about 85% of the time. If you just walked into this without seeing the narrow complex beats, you might think this is ventricular tachycardia. But it is aberrant supraventricular tachycardia. And this is treated with an AV nodal blocking drug. And we'll get the next slide here, I hope. There we go. So here's case 4, 84-year-old female with an irregular heartbeat. And again, this is another case of rate-related aberrant intraventricular conduction in the setting of a supraventricular tachycardia. Here, that supraventricular rhythm is atrial flutter. And it's got a very, very reproducible sawtooth. And here's that long interval. And here's the short interval and an aberrantly conducted beat. You can see one of those beats here, and it just has a left axis, but it doesn't appear to be all that much wider. For sure, it doesn't have a right bundle branch block pattern. So this falls in that 15% category of these aberrantly conducted beats that don't have a right bundle branch block pattern. So Ashman phenomenon, going back to the last case, can be in any supraventricular rhythm. It can even be with sinus tachycardia with a premature atrial contraction. Well, here's case 5. 62-year-old man who says, my neck is throbbing. Well, you look and you see there is an inverted P wave in lead 2, as well as in V5 and V6. So this is coming from down in the low atrium or junction. with a PR interval less than 0.12, it's probably junctional. And you know that a junctional focus can have an inverted P before the QRS, after the QRS, or simultaneously with the QRS. But all will have the same throbbing in the neck, because when that atrium tries to contract, the ventricle has already contracted. Those atrioventricular valves can't be opened up. And when the atrium contracts, it propels the blood retrograde into the neck veins. And that's the reason for the symptoms. If you want to make this go away, walk the patient sufficiently to have the sinus rate usurp the rhythm, and it'll go away. So here's case 6, a 44-year-old man with intermittent tachycardia. He's got the same low atrial or AV junctional rhythm, but notice how there's a delta wave. Well, the tachycardia is not present now, but certainly when you see a delta wave, you think with this accessory pathway, you could have the mechanism for atrioventricular reentry tachycardia, either using the accessory pathway as the antegrade path or as a retrograde path. Well, here's somebody who has tachycardia, 47-year-old woman. Well, it looks like it's a tall RNV1, but you can't tell if this is some type of reentrant rhythm or if it's an automatic rhythm. And let's see. So the patient was treated with an AV nodal blocking drug because the blood pressure would tolerate it. And notice how now there's atrial tachycardia with 2-to-1 conduction. Every second P wave is conducted. And the P wave that's not conducted is kind of hidden in that ST segment T wave. So atrial tachycardia is an automatic atrial rhythm. And so it's not a reentrant rhythm. Here's the next case. A 70-year-old female with nausea. If you look in lead V1, you can see she too has atrial tachycardia with 2-to-1 conduction. But nausea is something that is a side effect of a medication, as are these scooping ST segments, except in the right side of these where it's kind of convex as opposed to concave. Well, when this lady got put on digitalis, she had atrial fibrillation. And the rate was trying to be controlled because she had mitral stenosis. And you can see that by the right axis. And because she's developed pulmonary hypertension from the mitral stenosis. Well, now that she's become digitalis intoxicated, she has atrial tachycardia with 2-to-1 conduction, with 2-to-1 block. But let's talk about what else digitalis intoxication can do. It increases the atrial automaticity. Here's the atrial tachycardia instead of the atrial fibrillation that she had. It causes junctional tachycardia. She doesn't have that. She's conducting. It can cause ventricular tachycardia. Well, she doesn't have that either, or ventricular ectopy, nor that. But it does cause AV nodal conduction block. And she does have that. So measure a digoxin level and treat with digitalis antibodies if necessary. But if you just hold the drug, it'll get better unless she's not doing very well with the rhythm. Just so we can say we saw another patient with digitalis intoxication. This is a 59-year-old man who also had anorexia. And he was getting the digitalis because he had left ventricular failure, trying to squeeze that last bit of inotropy out of his left ventricle. He'd had a previous lateral and anterior infarction. And notice how with those cues, there's persistent ST segment elevation long after the myocardial infarction. This is an aneurysm. If you look at the supraventricular rhythm, there's sinus tachycardia. And these are normal P waves. He never had atrial fibrillation. But now he's got accelerated junctional, or actually junctional tachycardia. And dissociation. There's no association between the P waves and the QRSs. You'd say, well, is this, it's kind of wide complex, is this ventricular? No, let's say that this is junctional with an intraventricular conduction delay that has a QRS duration that's about 110 milliseconds, not quite enough to say it's ventricular. And knowing his past history, this is the way it was. Again, the treatment is the same. If the patient's rhythm is dangerous and the level is very high, then you treat it with digitalis antibodies. All right, changing gears. Case 10, 82-year-old female with a hip fracture. She fell. She didn't lose consciousness, but she couldn't keep her balance. If you look at the heart rate here, 1, 2, 3, 4, 5, 6 times 6, it's about 36. That's not enough for an 82-year-old to stay awake, or certainly to keep a good head of steam. You can see that there are B waves that should be conducted 1-to-1 regardless of her age, but they're conducted 2-to-1. Every other B wave is conducted with a constant PR interval. So this is second-degree AV block, 2-to-1 block. Is it Mobitz type 1 Wenckebach or Mobitz type 2? And for the fact that it's a wide QRS complex with left bundle branch block, this is Mobitz type 2. This patient needs a pacemaker, unless there's some medication that's causing this. But that's part of the history taking. Here's case 11, a 41-year-old man with canon A waves. And canon A waves, let's talk about those first. They occur when there's a P wave that occurs after the QRS. That atrium can't open up those atrioventricular valves that have just been closed by the ventricle. So they'll blow the blood back into the neck veins or into the pulmonary veins, depending upon if they're connected to the right atrium or left atrium. Some patients will sense this. And if you have a Swan-Ganz catheter in place and you blow up the balloon when this happens, you'll see those canon A waves in the pulmonary wedge pressure, pulmonary capillary wedge pressure. At any rate, here we have sinus rhythm and junctional rhythm. It's not fast junctional rhythm. It's just kind of doing it at a rate of about 50 to 60. And they're constant P to P and constant R to R and totally dissociated. So this is third-degree atrioventricular block with a narrow QRS complex. And the patient feels fine. It's you that complained, or whoever examined the patient that complained about these A waves. You don't need to treat this. He was born with it. He doesn't sense it. But as time goes on and he does physical activity, what's going to support his blood pressure is going to be muscle contraction. And when he stops and stands there, the heart rate is not going to be quite as fast. Certainly the ventricle or the QRS won't go anywhere near as fast as the sinus node, the P waves. But the blood pressure won't support it so much. And he's going to get dizzy. And that might be a time to support the heart rate with a pacemaker, but certainly not now. All right, here's a 54-year-old female with episodic tachycardia. And it's pretty fast. Don't see any supraventricular activity. So blood pressure is not too bad. After treatment with adenosine, well, the rhythm broke. And now there's sinus rhythm. But there are normally conducted sinus beats and sinus beats that are conducted down a bypass tract, an accessory pathway. And look at these accessory pathway inscriptions here. In lead AVL, they look like Q waves. Similarly, they look like Q waves in lead 1. In lead V1 and V2, they look like right ventricular hypertrophy. And out here in these lateral precordial leads, comparing this beat to the normally conducted beat, it looks like left ventricular hypertrophy with repolarization changes. So remember, if you're ever going to do a stress test on a patient like this, you need to have some imaging. You just can't go by electrocardiographic changes. And certainly when you see this electrocardiogram, you know that a rhythm like this is possible. And this is using the AV node as the anterograde limb and the accessory pathway as the retrograde limb. Contrast that with this case 13, a 42-year-old man with wide complex tachycardia. Here, you suspect that the anterograde conduction is down the bypass tract. If you give this patient some AV nodal blocking drug, it's going to favor conduction down the bypass tract all the more, and you'll regret it. So if you're going to treat this with medication, you should use procainamide. And if the patient is in not very good hemodynamic shape, synchronized cardioversion. But here's another way. Why don't you look at an old tracing? And there you can see a premature beat that's got an accessory pathway. So you don't need to know how to treat this patient. If you see the old one, you say, let's use that procainamide and use that if we have to use a medication. All right, let's go to case 14. This is a 74-year-old man with exertional weakness. He's got a pacemaker. It's in the right ventricle. It's pacing at about 60. But following each QRS, there's a retrograde P. So there's ventricular atrial conduction. Well, just like what we've seen in these other patients, whatever is collected in the atrium tries to pump into the ventricle, but it pumps it back from where it came. And so rather than getting that 15 to 20% of augmentation of ventricular filling, you lose that much. So these patients will have exertional weakness, especially as they get older. Well, it's an unusual patient who's old and didn't get an atrial lead with the initial pacemaker placement, but still has the ability to conduct. So just put in an atrial lead in this patient and combine it with the ventricular pacemaker, and you get atrioventricular pacing and cure the exertional weakness. This case is fun. It's a 96-year-old woman with a permanent pacemaker who presented with chest pain. And so her first electrocardiogram, not this one, showed a pacemaker. And I couldn't see anything through it. I couldn't figure out why she was having chest pain. So I tried programming it down as low as it could go. But as low as it could go, I think it was a rate of 40, she still was going slower. So I decided to leave it programmed just the way it was. And I reached into my bag of tricks and got a pacemaker, a temporary pacemaker with wires coming out. I put a suction cup on the end of each wire and put those suction cups on either side of the pacemaker generator and turned up the voltage just enough to inhibit the permanent pacemaker and show, but not enough to capture the heart. Well, here you can see I'm pacing at a rate of about 105. And you can see the sinus beats, and you can see the junctional beats with a rate that's quite slow and completely dissociated. This is third degree heart block, but that's why she had the pacemaker. But what I was looking for was ST segment elevation of myocardial infarction or pericarditis. Well, instead, I found T-wave memory. And that happens after a pacemaker is turned off. It happens after reverting from left bundle branch block to a narrow complex rhythm. Here, this lady had an incomplete right bundle branch block and T-wave memory. So after I did this, I stopped my diagnostic trial. She went back to her pacemaker rhythm, and I examined her more thoroughly and found that she had herpes zoster. So chest pain is not always from the heart. Here's another 97-year-old woman, came from a skilled nursing facility with a coma. Boy, look at the heart rate, very slow. Atrial fibrillation, long QT interval. And look at these J waves, Osborne waves. This is hypothermia. These last two things are artifacts. Well, her temperature was 33 degrees centigrade. And she had a CAT scan, and she had a stroke that involved her hypothalamus. She could not control her body temperature. So that had to be very closely watched. With rewarming, she woke up, and but it was a struggle to take care of her temperature, at least as long as I was taking care of her. Case 17, 58-year-old man with chest pressure. Well, there's something about this tachycardia that should set off an alarm. And that is that in V1, R is taller than R prime. That makes you think it's of ventricular origin, as opposed to supraventricular origin like the others we've seen. You come over here to 2, 3, and AVF, and you see Q waves. You say, does this patient have a scar? And this is ventricular tachycardia. Well, the patient had chest pain and needed synchronized cardioversion. After it was completed, there's the inferior infarction with persistent ST segment elevation. And that's the source of the scar ventricular tachycardia. But when you've got an aneurysm, think of other things. Think about heart failure and think about thrombus formation. Well, this next case, a 77-year-old man with an acute stroke, had the very same inferior infarction with ST segment elevation of aneurysm, with salvos of ventricular tachycardia with that same R taller than R prime. But this man was nice enough to interfere with his ventricular tachycardia enough for us to see the picture, but we couldn't see the thrombus. And indeed, he had a thrombus, and that was the cause of his stroke. So whenever you see this kind of ST elevation remote from the infarction, think about those three things: ventricular tachycardia, thrombus, and heart failure. All right, switching gears to electrolytes. 67-year-old female with diarrhea. Well, the rhythm is bigeminal. Look at those P waves. They're awfully big. They look like right atrial enlargement. But then again, look at this respiratory change in the size of the voltage here in lead 2. You see that with chronic lung disease. But how about these rhythms? Ventricular bigeminy. And look at this one QRS TU complex. You've got a flattened T wave, tall U wave, long QT interval, diarrhea. This is hypokalemia. The potassium was down to like 2.6, and with repletion, this all got better. I left it to the gastroenterologist to figure out why the patient had diarrhea. About a 62-year-old female who came into the emergency room unresponsive. Well, there's no atrial activity at all. And the ventricle is just beating, but not exactly fast. This would not be called ventricular tachycardia. You might call this accelerated ventricular rhythm or ventricular rhythm. It's not an escape rhythm, but it's a dangerous rhythm. These are just rhythm strips, V1, V1, lead 2, and V5. This is hyperkalemia. Well, after glucose, insulin, calcium, and some potassium binder, this was what resulted. Dialysis wouldn't be bad either. How about this 53-year-old man with lethargy? Lethargy. Well, look at that short QT interval. There's actually no ST segment. Well, short QT interval. Lethargy. Hypercalcemia. The calcium was 16.5, and the patient had sarcoidosis. A little bit of saline would help, but treating the sarcoidosis would too. 63-year-old female, status post thyroidectomy for cancer. Just the opposite. Very long QT interval. The ST segment is long. This is hypocalcemia. In the process of getting all the cancer, I think the surgeon got all the parathyroids, unfortunately. So it's going to be an effort to keep the calcium up, unless perhaps there was a piece of the parathyroid that was preserved and not implanted. That seems unlikely. Here's a 28-year-old man awaiting renal transplant. There is a very symmetrically peaked T wave. And that's still sinus rhythm, renal failure. I'm sure this is hyperpotassemia, hyperkalemia. Maybe this can just be addressed with diet or medication change. But certainly it's very different from that ventricular rhythm we saw where the potassium was dangerously elevated. This is an unusual case. 22-year-old female with laryngeal spasm and stridor. She sounded like it was an effort for every breath. The T waves are very much like the last case. And the long QT interval with that long ST segment were like the last case as well. So this is both hyperkalemia and hypocalcemia. If the calcium could be replaced, the stridor would go away, and it did. Now, I'm not sure if I showed you an earlier case where a patient had inferior infarction Q waves, and then a ventricular pacemaker, and you couldn't see the Q waves anymore. So in the presence of a pacemaker, you cannot diagnose an old myocardial infarction. But here's someone with a pacemaker that's having an acute myocardial infarction in the inferior leads. And look at the reciprocal changes. Measure your cardiac biomarkers, and you'll find myocardial infarction here. And this is reliable. So chest pressure, ST elevation, even with a pacemaker. So acute MI can be diagnosed, but not an old one. Here's a 45-year-old man with persistent chest pain, and it's 1 day post PCI of a proximal right coronary artery. The interventionist was very proud of himself, and as rightly he should be. But although that right coronary artery looked very good, he failed to realize that a branch was lost, and it was a right ventricular branch. And so in a patient who's had a proximal right coronary intervention with persistent chest pain, don't forget about a right ventricular infarction. And if you just have your standard precordial leads, V1 will be the best you can see the right ventricle with. Of course, it would be better if you put them on the right side of the chest. But if you see this, this is an RV infarction. And there's an explanation for the pain, and you need to keep the patient supported. 66-year-old man with lung cancer, worsening dyspnea. Well, there's electrical alternans here, and there's tachycardia. The combination of those tells you that this is cardiac tamponade. There's a swinging heart in the effusion, probably related to the lung cancer metastasizing around the heart. While you call for the echocardiogram, get that blood pressure cuff out and measure pulsus paradoxus. You'll be a step ahead. 44-year-old man with chest pain. Yep, this is the pericarditis we've been looking for. You can see there's ST segment elevation in every lead, except for these right-sided leads, AVR and V1. The T's are upright until the ST segments come to baseline, and then they revert. But let's just talk about this stage 1 of acute pericarditis. If you're looking for PR segment depression, it's not so easy to see here. But PR segment elevation in lead AVR is often the most reliable, and you can see it here. about a 51-year-old female with hemoptysis. There's tachycardia. The axis is getting more and more rightward. There's that P pulmonale. This looks like it's some type of acute cor pulmonale. Pulmonary embolism with the hemoptysis. I'm sure you know how to take care of this. So it's about building on basics. Make it easy, learn from experience, and don't miss a trick. Thanks. I'll stop sharing and answer questions and do anything anybody would like.
Thank you so much, Dr. Schiavone, for taking the time to walk us through cases. I think that's so helpful to provide context, nuance, and actually you gave us several before and after when you did some treatment there. So that was helpful. I don't know, as you were, of course, presenting, I ran a few polls to see what the demographics of our attendees here, and it looks like we do have multiple folks that are in the outpatient, or actually, excuse me, inpatient. There's 52% that work within the inpatient, 38% in the outpatient, and then a few there in the emergency department and the urgent care. And then in the second, looks like many order for cardiac risk, the preoperative cardiac risk assessment. And then sometimes as part of a cardiac risk for primary risk reduction, there are nearly 61% for suspicious anginal equivalent type symptoms. And then we had a few pre-participation physicals and symptoms of palpitations was about 61%. So we experience quite a few events of when we order these, and of course what the findings are. What would you say is your common, I guess, teaching point that you have for medical students, for residents, fellows, that common things happen commonly. What are the things that we as humans have a hard time identifying or really wrapping our head around? What would you say is a common thing that occurs in our training? Either we miss it, or it's something that you would say, these are the things that I would really pay attention to.
That's a good question. I think QRS axis is important to know. It can be as easy as just looking at 2, 3 in AVF or lead AVR to say, oh, we're heading in this direction. But if you can maybe spend a half hour someday reading over the rules of interpretation of QRS axis, that'll help a lot. And I think it's something that many are not equipped to do.
Yeah, that makes sense. I mean, if you know where the vector of electricity is going in the heart, you really kind of have a sense of where that disease is at or where it's coming from. That makes a lot of sense. Laura, do you have some additional questions, or I didn't see many coming from the audience just yet. Other than I think one of your EKGs had the accessory pathway, and there was a question of WPW.
Fantastic presentation, Dr. Schiavone. I think as we wait for anyone to type in questions in the chat, I wanted to thank our sponsors for tonight. Of course, EKGAction. APAC also works a lot with American College of Cardiology, As a constituent organization of AAPA, we are happy to be partners with them as well as the African Heritage Caucus. And here's a list of our board members, most recently adding Lauren and Kimberly as the Heart Failure Society liaison and Heart Rhythm Society. We welcome them and all of you, of course. Here are the Twitter handles for Viet and myself. If you have any questions or concerns, we're always happy to get a message and respond and let you know how to be involved. And we talked about the objectives. So really looking at the action potential, interpretation, and some of the tips and tricks of unique etiology. Some of us have seen a lot and others, the Canon waves I was not as familiar with. So that was really fun to learn more about. I would have thought pacemaker, but of course you have to remember symptoms are the most important thing. So thank you for that reminder, Dr. Schiavone. And just a little more information about the Association of PAs in Cardiology. Our mission is really to enhance the personal and professional growth of our members through different educational opportunities like this webinar, community involvement, political representation, and advocacy. We have a seat at the voting table for AAPA. We regularly do a PA Pulse blog. We'd be happy to have any of contributions from members here or listeners on the webinar about relevant topics, and also have a career center. So if you have any questions, we've listed our email and contact information here and how to connect on social media as well as through emails.
Yeah, I thank you for having run through that. Please engage with us on social media. Just know that one of my 10 years principal objectives is to really make our association of PAs in cardiology really collaborate with our subspecialty partners in cardiology. So as you saw, Lauren is going to help us liaise with the Heart Failure Society of America, and recently we reached out to the Heart Rhythm Society. Both Laura and I have committee positions within the association, American College of Cardiology. So if you're interested in if you practice a specific subspecialty in cardiology, or even if you don't and you would like to be a liaison and work with those organizations, please reach out to me.
Yeah, I had mentioned that I would show the expanded version of the 17.
Oh, yes.
And if I can share my screen again, what I can do is open that up, I hope. Let's see. I think this might be it. So it's those same 17 steps, but in each of the steps, I expound on what each of those diagnoses is and how to make that diagnosis. And if you take any of these underlined areas and look in EKGAction, you will find multiple examples of the electrocardiogram for these. So it permits me to make this into, only an 11-page document, whereas a textbook of electrocardiography would be certainly much more extensive. But if you know we've got maybe about 350 electrocardiograms backing up these different diagnoses, I mean, this is the value of having something online like this.
Yeah, absolutely. There was a question here from John. Can you review when procainamide is indicated instead of AV nodal blocking agents in tachyarrhythmias?
Sure. If you know you have WPW syndrome, that means you know there's an accessory pathway. And you know that if you give an AV nodal blocking drug, you're going to favor electrical anterograde conduction down the accessory pathway, if you've got something like atrial fibrillation and you block the AV node, now everything is going to go down that bypass tract without any type of pause. And so you'll take a rhythm that can maybe have a rate of 160 and turn it to a rate of 300, and the patient will really deteriorate. So either you use procainamide, which will block the ventricular conducting path, which is that bypass tract, or electrical cardioversion, synchronized.
That's
I hope that
really
answers the question.
helpful.
Yeah, thank you.
And I wanted to highlight, when we set out a recording of tonight's webinar, we'll also include a link to the program EKGAction, which is a program you can purchase to really dive in deep in some of the things Dr. Schiavone has really touched on, and is so easy to use and can really sharpen your skills in much more than the hour we have tonight, but highly recommend it from those of us at APAC.
Yeah, great. There was one final question. I don't know if we have necessarily the time for it, but this was, I imagine you do have experience with taking care of patients with WPW in AFib and when they have RVR and WPW, as I think you're explaining the treatment here. I don't know if you want to speak to that any further, Dr. Schiavone.
Well, if you talk to enough electrophysiologists who do ablation of bypass tracts enough, they'll tell you that that is how you determine whether or not somebody is safe with an accessory pathway. And that is, once in atrial fibrillation, if they go off to the races and become hemodynamically unstable, those are the people who need to be treated right away. I'm talking about they need to be ablated as soon as possible, or be put on a medication if ablation is not something they would want to undergo. But if the patient can go, can have atrial fibrillation and of course have some wider QRS complex because some of the electricity is going down the bypass tract and does not deteriorate hemodynamically, well, then it's not an emergency.
You have time to think about it.
Right.
Yeah. Great. Thank you, everyone. Well, we've come to the end of our time here, and Dr. Schiavone, so grateful for the time that you've given to us tonight. And the wonderful part is that, of course, we have EKGAction.com, and you will continue to partner with us, and certainly we look forward to ongoing webinars in the future. Actually, we'd love to ask you to come back sometime in the next few webinar cycles.
It was my pleasure. Thank you very much for the opportunity, both Viet and Laura. Thank you very much.
Great.
Thank you so much, everyone. Have a wonderful night.
All
Good
right.
night.
Bye.